OsteoSignal episode 33. This is OsteoSignal with Neal O'Neal, a podcast exploring how osteopathic science can help you decode the body's biomechanical, biochemical, and bioelectrical signals so you can thrive. And now, here's Neal.
Welcome back to OsteoSignal. I'm Neal O'Neal, and today we're going to go somewhere that most manual therapists and structural practitioners have never gone, into the gut. Today we're going to present the gut peptide quartet: GLP-1, GIP, GLP-2, and BPC-157, how four peptides govern gut integrity, immune regulation, bone protection, and why this changes how you treat every chronic pain patient. And as I said, we're going to go into the gut. So not the gut as a digestive organ. The gut is the body's largest endocrine organ, its largest immune organ, and the command center for signaling networks that directly govern bone metabolism, systemic inflammation, tissue repair, and the structural integrity of every patient you treat. And for those patients who are out there, every patient that we're treating. I want to start with a clinical question. How many of your chronic pain patients also have gut symptoms, right? Every patient comes in bloating, reflux, irregular bowel habits, food sensitivities, post-meal fatigue. If you're like most practitioners, you've noticed the correlation, but you may not have had a mechanistic framework for why it exists. Today's episode provides that framework. There are four peptides at the center of this story: GLP-1, glucagon-like peptide 1, glucagon-like peptide 2, GIP, gastrointestinal peptide, and BPC-157, that's body protection compound, or WIN57. The first three are endogenous gut hormones produced by specialized cells in your intestinal lining every time you eat. The fourth, BPC-157, is a naturally occurring fragment of a gastric protein that appears to orchestrate gut repair, immune remodulation, and tissue regeneration through mechanisms that overlap with and amplify the first three. These four peptides together govern the integrity of the intestinal barrier, the regulation of the gut immune system, the postprandial suppression of bone resorption, right after eating, suppression of bone resorption, and the body's ability to repair damaged tissue. When they're working correctly, the gut wall is tight, inflammation is regulated, bone is protected after meals, and tissue repair proceeds efficiently. When any one of them is disrupted by chronic stress, by poor diet, antibiotic use, metabolic dysfunction, or gut dysbiosis, the consequences ripple through every system we treat. If you've been following the OsteoSignal series, you know that the biomechanical, bioelectrical, and biochemical layers of healing are interdependent. Today's episode adds a layer underneath all three: the gut peptide signaling system that provides the foundational conditions for all of them to function. So this is a big episode. Let's get into it. So joining me today is Autumn Mayberry, a clinical manual therapist. Hey, how's it going? And
Great.
Brent Mayberry. And Brent Mayberry is our engineer, man on the street, man of good questions. So Brent keeps us straight throughout the whole podcast. So welcome, Brent. Welcome, Autumn.
Thanks, Neal.
Thanks.
This sounds like a really fascinating discussion, how peptides affect the gut.
Yes.
I'm excited.
Well,
this is coming up almost with every patient anymore. So it's nice. It's going to be great.
Well, and we see a lot of this. And anytime somebody has chronic edema and they have a source of chronic edema, as we saw in one of the previous podcasts, there was a study just done that was just finished last year that when there is a chronic inflammation, the chronic inflammation creates an environment that pre-selects for cells with aberrant genetics, right? So it doesn't cause cancer, but it selects for cells that don't have exactly the right genetic complement. And so initially cells will start to be a little odd, a little weird, and eventually they'll get more and more odd and weird the longer they're exposed to inflammation. So if we have gut inflammation, that will affect the entire body. And so like we said in the previous podcast, it doesn't select, chronic inflammation does not select for cancer, but it provides an environment where cancer can thrive. And we don't want that. We want our patients to thrive, not cancer. So yeah, this is going to be a doozy. All right, let's get into it. The L cell, where the story begins. Yes, that's L is in Leydig. Every time you eat, specialized cells in the lining of your small intestine and colon detect the arriving nutrients and release a cocktail of signaling peptides into the bloodstream. These cells are called enteroendocrine cells, and among the most important are the L cells, located predominantly in the distal small intestine and colon, and the K cells, found in the upper small intestine. The L cells are remarkable. They produce both GLP-1 and GLP-2 simultaneously in a 1-to-1 ratio by cleaving a single precursor protein called proglucagon. The same gene that encodes glucagon in the pancreas encodes GLP-1 and GLP-2 in the gut. And the difference is which enzymes are present in the tissue to cut the precursor. In the gut, right? So of course your body's playing chemistry set here. And so just which part of the molecule it snips causes it to be a GLP-1, a glucagon-like peptide 1, or a glucagon-like peptide 2. So in the gut, prohormone convertase, 1/3 cleaves proglucagon into GLP-1 and GLP-2. In the pancreas, a different enzyme produces glucagon instead. So you can see this is a very complicated setup. It's a very elegant biology because it means that every meal triggers the simultaneous release of 2 complementary peptides, one that governs metabolic regulation and immune modulation, GLP-1, and one that governs intestinal growth, repair, and barrier integrity, GLP-2. The gut senses food and immediately launches both a metabolic response and a structural maintenance response in parallel. Pretty cool. Meanwhile, the K cells in the upper intestine are releasing GIP, glucose-dependent insulinotropic polypeptide. We always like to give them nicknames, but yes, there's the full long glucose-dependent insulinotropic polypeptide, which has its own set of effects of insulin secretion, fat metabolism, and, critically for our conversation, bone metabolism.
So Neal, real quick, you mentioned both pro-glucagon and regular glucagon.
Yes.
For people like me, I don't know, where does that come from? Like, I'm sure I know it comes from our food, I guess. Is that accurate?
The proglucagon is produced in your liver.
Okay. And then does your pancreas produce, it says pancreas, produces regular glucagon. Is there any considerable difference between those two?
Well, proglucagon is a precursor to glucagon, right? So it's going to be glucagon, primarily in the alpha cells of the pancreas and the L cells of the intestine. Also in certain areas of the brain, surprisingly. So in order to become glucagon, it has to be processed by an enzyme in the pancreas. In the intestines, it's going to be that different enzyme is going to act on it, and it's not going to become glucagon. It's going to become glucagon-like peptide 1, and then glucagon-like peptide 2. So you've got this proglucagon. It can actually go down one of 3 pathways. If you cleave it in one place, it becomes glucagon, which is a signal to your liver. Or otherwise, if it's clipped in a little slightly different place, it'll become GLP-1 that goes to the brain, mostly to the brain. GLP-2 will go to the rest of the gut, saying, hey, let's do these other things. For example, stimulate insulin secretion, right? So obviously that would go to a different part of the pancreas, stimulating insulin secretion. It will regulate appetite up in the brain and maintain the intestinal lining, right?
Okay.
So that's the GLP-1, GLP-2 the GLP-2 is going to help maintain the intestinal lining because you're going to have a lot of mechanical action of the food getting beat up by the mucosal lining. And so that mucosal lining is going to get beat up. So you have to send a signal saying, hey, now's the time to replenish the gut wall lining. Yeah, to fix yourself. Start fixing yourself now because there's a bunch of rough stuff coming through here and it's going to abrade and wear and tear and tear at us. So let's get cracking right now.
Gotcha. So proglucagon is just like the raw material, and then
it's the yeah, exactly.
Yeah, and then your body will convert it into one of those 3 things that you mentioned: GLP-1, 2, or just regular glucagon.
Correct. Exactly.
Okay.
And those are all different signaling. Yeah, makes it a little more clear, hopefully.
Yeah, kind of helps explain. And does all the precursor, all that raw material, come from the liver, or do you get it from other sources as well, or does your liver convert your food into that raw material?
Actually, the proglucagon is produced in the alpha cells of the pancreas and the intestine. So I misspoke. It's actually in the pancreas and in the intestines, right?
Okay.
Glucagon is a signal to the liver.
I see. All right. So it comes from alpha cells in the pancreas and also in part of your
L cells of
intestine.
the intestines. Yeah.
Okay. Awesome.
Exactly. Right. So yeah. So the glucagon's produced in the pancreas, and then that also causes insulin to be produced, right, which is produced in the pancreas, and then goes and affects your liver, right? It prompts the liver to release stored glucose into the bloodstream.
I see.
Right. And so there's where we talk about a lot of like the whole ring of diabetes and how it happens, or how the improper insensitivity to insulin, or insensitivity to glucagon to release insulin, or the inability of the liver to pay attention and release insulin or release sugar appropriately, right? So there's type 1, type 2 diabetes is what we're looking at there.
I see. All right. Thanks for taking that detour. I just wanted to kind of understand, more about these biochemical signals that we tend to talk about. So thank you.
Yes, no problem. Okay. So that let's.
So we were talking about like bone metabolism, and then you're going to mention something about those peptides, those 3 peptides.
Right. Okay. So let's. This is elegant biology because it means that every meal triggers a simultaneous release of 2 complementary peptides, one that governs metabolic regulation and immune modulation, GLP-1, and one that governs intestinal growth, repair, and barrier integrity, GLP-2. The gut senses food and immediately launches both a metabolic response and a structural maintenance response in parallel. Meanwhile, the K cells in the upper small intestine are releasing GIP, glucose-dependent insulinotropic polypeptide, which has its own set of effects on insulin secretion, fat metabolism, and, critically for our conversation, bone metabolism. These 3 peptides, GLP-1, GLP-2, and GIP, are the endogenous gut hormone triad. They are released with every meal. They act through distinct G protein coupled receptors on different target tissues, and together they coordinate the body's postprandial, after meal, response across metabolic, structural, and skeletal domains. BPC 157 sits in a different category. It's not an incretin hormone like the other 3. It's a pentadecapeptide, right? A 15 amino acid fragment isolated from human gastric juice. It's constitutively present in the stomach. It's stable in gastric acid, and it appears to function as a master regulator of gut repair and tissue protection. So I'm going to cover each peptide separately, and then we'll show you how they interact. And then just an aside, I do want to tell a little story here about BPC 157. I think most everyone has heard of the story of Pavlov and the dogs, ringing the bell and the dogs would salivate, right? So we call that operative training. And so what he was using that for is that he actually had holes in the stomachs of the dogs that he was training. And what he was doing is he was draining their gastric juices so that he could pull out BPC 157 and use that for health elixirs for people, and actually was very very effective, and so he's making quite a bit of money, but he couldn't feed the dogs and have the food in their stomach and then try to get the gastric juices, because obviously food in there, nobody wants to drink that or eat that or have that injected into them. So what he did is he trained them to salivate and produce gastric juices because they knew they were going to get fed, and he would ring the bell and they would secrete the juices. They would come out of a tube and he would fill up these little bottles, and then he would plug the tube and feed the dogs. And so then that's where BPC 157 originally began. But it's also something that, as I said, it's a derivative of a stomach hormone we already have, or a stomach protein we already have. So we have our own.
So it messed up the dogs after that.
Right. Every time they heard a bell, they'd start salivating, right?
And then they can't digest things right.
Right. So here's the whole thing. Yeah, that he just, so all that, everybody hears the story about he trained the dogs to salivate when there was a bell.
Why did he do that?
Yeah, why did he do that? Well, so he could get
Paul
BPC
Harvey, the rest
157.
of the story.
Exactly.
Yeah.
And now the rest of the story. Yeah. So there you go. There's why Pavlov was training the dogs in the first place. So this is why when people go out and get BPC 157, you want to make sure your source is good. Because, and that's the whole thing, actually kind of speaking to the quality here, that, almost all of this stuff comes from China. So you almost can't even now. There are compounding pharmacies here in the United States that are doing it, but right now it's been pulled off the FDA has pulled it off of the shelf, saying you cannot give this. It's for research use only. Obviously, there are some like the GLP-1, GLP-1 with the GIP. Those are available. And then under certain diagnoses, like human growth hormone, obviously insulin's available. That's a peptide. However, all the other ones have been pulled off because the FDA is looking at them and trying to determine these. Now, in the past, these were just on the nutraceutical list, right? They were just for nutritional supplements that people could take, and the FDA didn't look at them and didn't watch their quality, didn't watch what exactly was going on. But now that the GLP drugs and et cetera have become, very important and they've been determined to be very important, the FDA pulled them off the list. And here in the fall, we're expecting that they will bring them and put them somewhere on that list of Schedule 1, Schedule 2, Schedule 3. Schedule 3 is things like, Schedule 1 is highly restricted, Schedule 2 less restricted, and Schedule 3 is the least restricted. And so it would still give them like, here's when that can be prescribed, et cetera, et cetera. But at this point, everything's been pulled off, and technically only a few of them, GLP-1, GLP, and GIP, are available legally. So there's lots of gray market, and a lot of the peptide producers, the compounding pharmacies, have just closed their doors, saying we're just going to wait, or they're only dealing with the GLP-1, GIP. But as you notice, our discussion includes GLP-2, and I don't think most people have even heard that there is a GLP-2. So here we are. Again, people are still getting these on gray market, and those that are, you have to be very careful who you're getting it from. What's the quality? You have to question what's the quality. There have been several instances where people are getting something, or at least they think they're getting peptide A, and they're actually getting peptide Z. And so it won't have the effect that it's supposed to have. So it is important to be certain of your sources if you're going to use this stuff. And there are some that do third party. They have third parties go through and check their peptides to make sure they are what they say they are, and that they are the quality that is required. But again, a lot of that is done offshore, and then people are getting them here in the States. So I don't want to really speak too much farther than that, other than try to be very careful. If you're using this stuff, please try to get very clean, appropriate sources. Okay, anyway, so we won't play Pavlov here. We won't go get them from people ourselves. We'll let somebody else do that. Okay, so let's talk about these individual peptides. So GLP-1, as I said, the source is the L cells of the distal small intestine and the colon. The receptors of the GLP-1 are glucagon-like peptide 1 receptor. Those are in the pancreas, right? Obviously, the pancreas is going to produce it to cause it to affect insulinotropic cells in the pancreas. The brain, there are receptors in the brain, other portions of the gut, and immune cells. Okay, so very important to our discussion here, very germane. Okay, the primary functions: glucose-stimulated insulin secretion, appetite suppression via gut-brain axis, slows gastric emptying, anti-inflammatory, right? So it does have some positive effects from an anti-inflammatory effect, particularly in the gut, and intestinal barrier support, very important. Now, those primary functions in the OsteoSignal, we're concerned with immune modulation, downregulates pro-inflammatory cytokines, very important, supports M1 to M2 macrophage transition, meaning the macrophages aren't as touchy or angry, and they're much more specific. Indirect bone protection via metabolic regulation, all good things. So GLP-1, it definitely can have side effects, and it has to be taken in the right way, but you can see why physicians, the medical community, feels that they're so important that they're okay to go ahead and do, even though there can be some downsides to it. Now, GLP-2, those same L cells, co-secreted 1-to-1 with GLP-1. So if there's one GLP-1 produced, there's one GLP-2 produced. Their receptors, GLP-2, are in the intestinal subepithelium, so below the surface, and the enteric neuron. So your intestinal tract is actually covered in neurons, and we've covered this in various ways. So osteopathically, you have sympathetic and parasympathetic innervation into your intestinal tract. And those those nerves are on an outer, a sublayer, let's call it, of the subepithelial layer in the GI tract. So this GLP-2 will go and affect those enteric neurons. So there's sympathetic, parasympathetic, and then what we actually call the enteric nervous system, a third part of your autonomic nervous system, so that the gut runs itself. Now, what that tells you is that these enteric neurons are connecting one end of the gut to the other end of the gut. So it's helping the intestinal tract know what's going on in various levels. For example, when food comes into your mouth, lower down in the intestinal tract has to know it. So those enteric neurons will start causing the production of certain chemicals and saying, hey, we need to get ready for this much fat, this much protein, this much carbohydrate, right? So we need these enteric neurons. And obviously that's also going to have an effect on your sympathetics and parasympathetics, because they help turn up or turn down those enteric neurons. So you can see the relationship here. Okay, now what are the primary functions of GLP-2? Intestinal crypt cell proliferation, right? Now, basically, if you think of diverticulitis, the diverticula at the bottom, we call these crypt cells at the bottom. Stem cell expansion, so cells that produce more cells. We expand the number of those. Sounds like a good deal. Intestinal growth, mucosal barrier repair, increased nutrient absorption. Hey, this is all sounding pretty good. Why aren't they prescribing this GLP-2 already, right? Particularly with the people that have a problem with the GLP-1, where they're not either absorbing the nutrients appropriately, right? They're not getting all their protein out of that. Also, that's one of the problems with GLP-1 is people are not replacing their calories. They may still be eating, they're still picking their calories out in the way that they had normally gotten them. And let's say they're picking potato chips instead of picking a protein source. And that's where the hypoproteinuria or the low protein is coming about. So, but GLP-2 also helps absorb nutrients even better from the food that is there. So you can see how a GLP-2 would be advantageous. So GLP-2, why we care about that is OsteoSignal, right? And why we as manual therapists, when we work on the gut, we're actually inducing direct gut barrier repair. We help prevent endotoxin translocations, right? Reduces systemic inflammation at its source, supports nutrient absorption for metabolic triad, right? All really good things. So you want GLP-2s to be produced. And this is going to be one of the places where, if we're, let's call it supplementing, right? If somebody is taking a GLP-1, or even, so like Ozempic is a GLP-1 only, or Mounjaro is a GLP-1 in a GIP. But notice in there, we don't have a medication that gives us a GLP-2. Now, somebody might say, hey, Neal, what about retatrutide? I've heard about retatrutide. That's got to have GLP-2. No, actually, retatrutide, GLP-1, GIP, and glucagon. Primarily, that was brought about for people who have type 2 diabetes, obviously. Their inflammation is gone, their digestion is better. Then they've gone from the Ozempic to the Mounjaro, but they still aren't losing weight there. They're very resistant. So some people might still be obese, have all the benefits. They're no longer type 2 diabetic as long as they're on this medication. However, they can't get rid of the weight, which also has other consequences, right? I mean, we also know about the estrogen effects and just the weight on joints, et cetera, et cetera. And so to get their weight and their body composition back to what we would want, that's where this retatrutide comes in, but that's not a GLP-2. So as of right now, you can see that in some ways, the medical community is a little behind on providing all of the medications that might actually be very helpful, because there are people who are not helped by the GLP-1. And so you're thinking, I think maybe the GLP-2 is what should be added in. I mean, I'm not saying that. I read that from people who are smarter than I am. So you see that. So you're like, okay, well, that will be coming. That will be coming. Let's move on to the GIP. The K cells, they're produced in, GIP is produced in the K cells of the upper and small intestine. Of course, GIP receptors in the pancreas, bone, adipose tissue, brain, and the gut stroma, right? So, right. So the connective tissue, right? And we talked about that, the barrier support, the mucosal tissue. So that supportive connective framework of the intestinal tract.
I just want to say, I love that you included this because as a practitioner, and even with the stuff we've been talking about with the ferritin and transferrin and the different hormones that are coming in based on people's numbers when they bring them in, and we can kind of ping those off of each other and make sense of them. It's really so much easier to not have to guess where you should apply treatment and what kind of techniques to use. It's really nice, and it's you don't have to guess like multiple visits either. You can start helping them right away, and they really appreciate it. And it feels good to be able to be like, I don't have to sit and wonder. It's nice. So I appreciate you doing all that.
So why don't you give us an example, Autumn? Like what would you go after having this information? Like, because I think patients certainly want to know that, and other practitioners want to know that. Like, what specifically, like, how would this change what you're doing? Like, I know we've talked about a patient, so let's give us an idea.
Well, usually when I have patients that ask about this or that we're wondering about their iron levels and stuff, there's a lot of problems, like we said, with the gut, right? And so treatments that we've gone over, especially lately in class, like the mediastinum and making sure the different organs can slide along each other, and they've got good blood flow. I find a lot of people in this situation have a lot of congestion around the biliary tree, around the pancreas and hepatic portal area. So we clear that out and we make it so that the body can just drain overall. And then I go after like hematopoietic centers and stuff like in the shoulders, because that's always locked down. The neck and shoulders are always really tight with this too. And then, the hips don't usually want to internally rotate. So getting things to kind of flow globally really helps, but also knowing, hey, if we've got a problem with hepsin, or if we've got ferritin, we've got high levels of ferritin, but we don't have them in these, these other things that we'd look at also, then we can kind of figure out what stage those are at and apply treatment to, okay, we're going to treat at the distal end of the small intestine, right? Or we're going to do it at the liver, we're going to do it around the stomach, or even up through the heart. Everything dumps on the heart eventually. You end up having to loosen that up too. But you get these pain referrals that kind of explain, why is my neck and shoulder not feeling well? Because the gut's irritated. And they're also thinking, and by the way, do you think I should go on GLP-1 or Manjaro, or all these different, peptides and things? And they're kind of those symptoms kind of flow over. And so they might come in with a sore shoulder or neck, but then we're going, yeah, but in that kind of a pattern, it's a foregut problem, or it's a problem with these. And then we're looking at, they don't have energy and stuff. So it kind of just flows back and forth. And we're like, we got to check the iron, we got to check the transferrin, we've got to check all these other things. But then we can apply treatment based on what seems to be more normal and where the hang up seems to be, what part of that chain and what that circuit looks like, and then apply it better. And then as they adapt, because they start doing that right away, they come back for another visit like, okay, well, now it's doing this. But knowing that circuit, then we can go, okay, well, it looks like we maybe need to provide more treatment here. And so you're not lost. It's just really nice to have like a guidebook that you can be like, I can take any patient that comes in, and knowing these principles, I can manipulate the treatment based on what they need on that day. So did that answer your question?
Yeah, no, totally. And
Okay.
I think that if patients are going to take these, right?
Mm-hmm.
And then the people that don't work as well for, how would we make them work better? Their body can't respond appropriately because the nervous system, they cannot function appropriately. Their gut can't function. Either they have too much inflammation, and like you said, you go to specific places, like I'm going to go to the liver, because if you have high ferritin, but they still have, but their their transferrin saturation rate is still really high, you go, wait, that's incongruent, because the body really, really wants iron, but it has iron available, but it must be locked away by hepcidin, which is produced in the liver. So the liver is seeing inflammation in the body, and it's reacting to it and producing the hepcidin, locking up the iron. So you go and treat not only T5, 6, T7, right, in the mid back. So these people with mid back pain, you treat the liver, you treat the diaphragm, you treat that. Then you say, well, then that must be affecting the pancreas. So you go over and you treat the pancreas at T7, T8, knowing why that rib or why that vertebra is sore, how that might affect them. You go after, you say, oh, well, then we have to do our general release of lymphatic drainage, right? You have to go up to the left thoracic inlet. You might check the right lymphatic, inlet, check the diaphragm, check this, like you said, it's just directing you from place to place to place. And then what you see is that this biochemical factory that we have going on in there now can function better, because, and we were talking about enteric nervous system that runs the system by itself. The thing is that the inflammation can knock that out of whack, or past insults like infections or illnesses people have had a virus. People, Montezuma's revenge or whatever that means. Previous surgeries, pregnancies, right? I mean, so all these things knock these things out of whack. And this patient goes, oh no, I don't know, I have bloating, but I don't have any reason for that. But I have this mid-back pain. And exactly what you're saying is being able to follow that through and understand, how does that guide my treatment? Do I go up? Do I go down? Do I go over? Do I come over here? What am I going to do with it? And how do I explain this? How do I understand where this is going? Not only in a biomechanical system, not only in a biological system, but in a biochemical system on a very high level. And so then that's where people are going to start taking these medications, and they may not get the results that they expected. I have one patient, she was on a GLP-1 for a long time. She had lost some weight, but she has this chronic low back pain. And of course I went through and I'm looking at her going, well, there's a reason your GLP-1's not helping you lose weight. It's because it's so effective at slowing down your gut that you are getting really bad constipation. And she goes, oh yeah, I have really bad constipation, but I manage it. I do this, I do that. And I'm feeling through her hindgut here and her descending colon, her sigmoid colon, and it's just absolutely packed full of stuff. And and she goes, oh, and of course I released this, and she goes, my back feels a lot better. It's like, well, of course your low back feels a lot better. You're not being torqued to the left by all this massive stuff in your gut there. And then of course she'll come in and she goes, well, my back's tweaked, but nothing's wrong. I'm not constipated, I swear. And of course I'll go through there. She goes, oh, I'm constipated. How did you know? But it's knowing, no, I have to go there. You're having low back pain, as opposed to, oh, no, you're having right mid-back pain or even central mid-back pain. Like, oh, I need to go here. Exactly as you say. I mean, I think that's really the power of it. Now, I do want to point one thing out, GIP, and gastrointestinal peptide, glucose-dependent insulinotropic polypeptide. There's another name for it. It's also called gastric inhibitory polypeptide. So here's one of the problems with this is first off, there are several names for like GIP, and what GLP says. It's glucagon-like peptide is the official one, not glucose-like peptide is sometimes people put the wrong thing down. So we all have to be very careful to keep the words correct, because it changes what it was really meant by that. But I did want to point out GIP, glucose-dependent insulinotropic polypeptide. And insulinotropic means helping have the appropriate amount of insulin, right? It depended upon if you have the right amount of insulin for the right amount of glucose, and this peptide is supposed to help make sure that happens. Obviously, within that, you're going to say, hey, right there is going to be a partial basis of insulin insensitivity, because if you don't get the right amount of insulin for the right amount of glucose, the system's not going to respond appropriately. And then over time, any response is going to degrade. Okay, I wanted to point that out. That's pretty cool. Yeah. So thank you for that, Autumn. That was
and
exactly
I appreciate what you
said
too, because, that constipation example, because, it makes you think, okay, well, now I have another thing to consider when I have someone that says they have Crohn's or IBS, and go, maybe we should check, see how the rest of the gut is firing, instead of just maybe you're dry over here and maybe you're stressed, maybe that kind of stuff too. But it's just another thing to think and say, maybe there's something deeper. Maybe we're not looking deep enough, and we can do more.
Well, and that's where I think that patients that want to go on these medications, and they still need appropriate care. They need informed care. They need somebody that knows what's going on with those peptides. Because honestly, first off, the physicians do not look at the world like from the osteopathic viewpoint. They just don't. It's not, no bent on them. It's never been exposed to them. They think in a very high level chemical only, and that it's like, oh, we're doing a perfect chemistry experiment at all times. Everything's perfect. There are generally not things causing us problems. That's the gross over exaggeration, but you get my point. So yeah, so we're the ones that should be helping, like physically helping people with these, but also being able to read why. And so, for example, this patient with the GLP-1, I said, well, why don't you have a conversation with your physician and let them know that you keep going in this and you're not losing the weight you want to. We really want to get you onto the GLP-2, the Mounjaro, move on to the GLP-1 and the GIP, right? Glucose, because it regulates glucose-stimulated insulin secretion, inhibits osteoclast activity. She was osteopenic, promotes osteoblast bone formation, and attenuates the gut, right? Helps keep the gut moving appropriately. And I think that's her whole problem, is the gut's not moving appropriately. She's obviously still absorbing calcium out of her bones when she should be absorbing it out of her food. So GIP, direct bone protection, suppresses the CTX1, increases P1NP for those that are big the chemical nerves, the gut-bone axis mediator. I want you guys to hear that again. The gut-bone axis mediator. Your intestinal tract and your bones, the cells of your bones work together. It also attenuates, so GIP, gastrointestinal peptide is what we're going to call it, attenuates gut inflammation via stromal CD146 plus cells. All that means is that the structural aspect of your gut doesn't get inflamed, like on as the support structure. So that's what GIP does for us. So that's why, so I'd suggest, why don't you talk to your physician? I think that you're maybe having some problems, especially with all that feces sitting in there in the hindgut, not coming out. You're going to have a ton of inflammation and irritation because it's going to overwhelm, like just mechanically, it's going to abrade, it's going to rub the walls of the intestinal tract. And I'm coming in there and helping release it to try and get it to move. And of course, that would clear things up, but it's like, yeah, well, that's all, damaging to the gut wall. And so that needs to be repaired. And so maybe a GIP is appropriate. So she is now on Mounjaro. So the physician moved her up, and she's still quite heavy. And so at some point, she's fine with that for the most part. She has a little bit of, I don't want to be quite this heavy. She has a lot of knee problems, ankle problems, obviously with the extra weight. And so at some point, let's see how this goes. But if this doesn't work, then say, oh, why don't you go question your doc and ask him and just say, I'm still resistant here. Maybe I'd move on to the retatrutide by adding, and I didn't really talk, we're not going to talk a whole lot about that in this one, but that, like I said, that's really for people that are weight loss resistant. Their body just will not give up the weight. There's different signaling for that. So, okay, perfect. Now let's throw this other one in, the BPC 157, which is not like the other three, right? It's like we're back on Sesame Street. Which of these ones is not like the other?
We're anyway, like Retro Day, right. Paul Harvey and Sesame Street.
I know, we got them all.
Wow.
Yeah. But the oldies but goodies, we're here, folks. Yes. It's still here. All right. So it's a gastric juice. It comes from the gastric juice. There's multiple receptors throughout the body, VEGFR2. Think of it this way. For the growth of, or angiogenesis, let's say that. Angiogenesis, and when you say the word angiogenesis, every medical person is going to go, oh my gosh, be careful with that. It can cause cancers to be able to get arteries and grow. And that's very true. Not for the cancer thing. That's always a concern with any drug or medication or anything that leads to angiogenesis. We always have to be very careful about that because the body has to keep blood flow away from tumors, otherwise the tumor will grow. And tumors are always trying to get themselves blood flow, and if they do that, then they grow. So also the nitric oxide system, which nitric oxide causes the capillaries to open up to allow the red blood cell through, so you get better perfusion. And also FAK paxillin. So focal adhesion kinase, and many of you may have heard this in class, but so what causes post-workout pain or post-workout soreness, right? That day or two after you've worked out and you're really sore, your muscles are tight and sore, and everyone's like, oh, we know what that is. It's lactic acid. No, that was disproven in 1952. I was going to say that to taunt you. Neal, that was proven in 1952. Because I know that was lactic acid.
Yep.
You knew where I was going with this. Yeah. So the actual chemicals that cause post-workout stiffness are ERK and FAK, F-A-K, paxillin. So interestingly, BPC 157, and BPC stands for Body Protection Compound, works on the FAK paxillin and on growth factor receptors. Okay, so primary functions, angiogenesis, tight junction repair. So tight junctions, remember, in your intestine, you have cells, and the food is going along, and they have these tight junctions so that not just anything can get through there. Same with the arteries, same with several places, blood-brain barrier. So that tight junction repair, maintaining that, because, for example, leaky gut is where those junctions have kind of been beat up, and all of a sudden there's space in between there, and now organisms or other things in the intestinal lumen can get in behind and into the bloodstream because those tight junctions aren't maintained. So BPC 157 for somebody with leaky gut, hello, folks, guess what? Growth factor upregulation. The EGF, FGF, et cetera, all those factors for angiogenesis, nitric oxide modulation. So for those people that are chronically stiff and sore, the nitric oxide helps cause connective tissue to loosen for example, in the veins and arteries. I notice also, what is it that people take when they have angina? Don't they take a nitrous? What is it called?
Nitroglycerin.
Nitroglycerin.
Not
Yeah,
The nitric
nitroglycerin.
oxide. Yeah, there you go. That's why. And it's also an anti-inflammatory, and it provides cytoprotection, protection for cells, keeps them from being destroyed early. So as far as OsteoSignal relevance, what we are concerned with, it's a master repair peptide. It restores gut barrier, protects against NSAID damage, non-steroidal anti-inflammatory damage, right? There's damage to various structures with NSAIDs. That's why you shouldn't just be taking them all the time. Supports tendon, ligament, muscle healing. And it's stable in gastric acid, meaning that it's oral bioavailability. In other words, it's one of the few peptides you can take orally without worrying that it will break down. Most of the other peptides you have to take with an injection because the stomach acids will break them down and they won't work. And various groups are like, oh no, we've got Zepbound or whatever, and it's like doesn't work nearly as well. Yeah. Okay. Anyway, there's our overview of those things. So moving on, let's move on to GLP-1, the metabolic regulator with an immune secret. Okay, so there's some hidden information there. Glucagon-like peptide 1 is the peptide that everyone has heard of thanks to the pharmaceutical revolution around GLP-1 receptor agonists like semaglutide and liraglutide, Ozempic. But the clinical conversation about GLP-1 has been almost entirely about weight loss and diabetes. What's being missed is GLP-1's role as an immune regulator and gut barrier protector. And that's where the OsteoSignal relevance lives, right? This is what we thrive on, is knowledge like this. GLP-1 receptor is expressed on immune cells, including macrophages, T cells, and intestinal intraepithelial lymphocytes. When GLP-1 activates these receptors, it downregulates pro-inflammatory cytokine production, specifically tumor necrosing factor alpha, interleukin-6, and interleukin-1 beta. These are the same cytokines we've discussed in prior episodes as drivers of the acute inflammatory response, the M1 macrophage polarization state, and the chronic inflammatory loop that perpetuates tissue breakdown, right? So that's why you're beginning to see that GLP-1 is being prescribed for people that don't have diabetes, but instead they have cardiovascular disease, which is chronic inflammation of the cardiovascular system. So you're going to see this more and more because also, and I'll be interested to see which way this one goes, because cancer is an inflammatory state. And if this downregulates inflammation, then cancers are going to have a harder time growing. So I think you'll be seeing this slowly but surely. This is going to be used more and more. The problem is that if there's not enough money in it, the pharmaceuticals will not do the studies to get it shown to be effective and to be prescribed for those things. So already there is off-label use. I think there's going to be a whole lot more off-label use. And it may or may not be one of those things that as we go along that the studies will be done, but we'll see. Okay. In the gut specifically, GLP-1 receptor activation on intestinal intraepithelial lymphocytes has been shown to directly alleviate gut inflammation in animal models. This is not an indirect effect through blood sugar control. It's a direct immunomodulatory action at the gut wall. So a lot of what we're doing with our hands with visceral mobilization, visceral manipulation, is being done by this chemically. So it's a huge boon to that. I mean, like I said, we have a lot of patients with a chronic inflammation in their intestinal tract, and it hasn't been being treated in the past. So here's one reason that people would want to do this if they have chronic gut inflammation. GLP-1 also supports intestinal barrier function by stimulating crypt cell fission, the process by which stem cells at the base of the intestinal crypts divide and produce new epithelial cells to replace the ones that are continuously shed from the villus tips. And the villi, your intestinal lining, like here's a tight junction, and here's a cell, and here's a cell, and they have these microvilli, right? And the crypts are down in here. So actually you'll have multiple cells making these up, but the crypts are down in here in between. And so they'll keep replacing the epithelium so that the epithelium lines here, as the food goes across it braids. Now, ideally there's mucus all along here that's helping to protect that. But again, back to these people with like constipation or this inflammation. Inflammation breaks down the mucus, so the mucus covering is not there. So there's more abradement, and there's more just wear and tear on the tissue. The more mucus you have, the less there is of that, but there's still going to be wear and tear on the intestinal tract. So the more, and then obviously that's going to lead to the more destruction you have of that gut wall, the more inflammation you're going to have, the more irritation you're going to have. That's where H. pylori, for example, H. pylori is resident in almost everybody. It's normal. Unfortunately, if you have a hole in that wall, then the H. pylori gets in there and keeps it from healing. And that's what, why H. pylori is so pernicious, is that it gets in a place that it's not supposed to be, much like a staph infection. Staphylococcus aureus lives in your skin, but if there's a break in the skin, it gets inside the skin, and now it causes an infection. So it's a normal bacteria until it gets in the wrong place. H. pylori, normal bacteria until it gets in the wrong place. And that's one of the things that GLP-1 helps overcome, is that you make sure bugs that live right in your intestinal tract don't get in the wrong place. So for example, the intestinal epithelium replaces itself every 3 to 5 days. That's a whole lot of turnover, folks. GLP-1 supports the rate and quality of that replacement. And through the gut-brain axis, GLP-1 modulates appetite, gastric emptying, and the vagal signaling that connects gut function to central autonomic regulation, meaning that your hypothalamus, right? We've talked about the neurohormonal axis, the hypothalamus, pituitary, thyroid, gonadal, adrenal axis, not only the hormones, but also your hypothalamus, sympathetic, parasympathetic systems, and how they keep the health of your body. So GLP-1 acts directly on that as well.
And we use treatments that target those specific parts of that as well. And so we can come at it from all those different angles.
And there's the hard thing, is sometimes we have patients who are they're, problematically, they're so resistant. We can help them, but we can't always get them over the hill and get them to the promised land of like pure health, right? That's very difficult to do. And then even if we do with a treatment, they go off and live their life, and they go back to the same situation that helped get them there in the first place. So then they set this all off. So the GLP-1 is a great way to help take care of some of that. And then when we treat them, the treatment will have a much greater effect. And just like you were alluding to earlier, like if you don't have the appropriate ferritin, or you don't have access to the ferritin, our treatments are not going to be as effective. Once the patient has access to ferritin, then and iron at every level, and then they can produce the energy. Their mitochondria can produce the energy to make the changes that we've induced in them, right? Like we, with our hands, induce a change. Their cells, through mechanical transduction, take it in and say, oh, we've received a signal. We should do this. Here's our plan. We're going to change. And then they don't have the energy to do it because they don't have the ferritin, right? In this case, if they have the ferritin, but also there's also more than that. Do they have the GLP-1 to help them not only affect that change locally, but can they affect that change globally, regionally, right? So you can see how this moves out. So the GLP-1 is a wonderful medication, a wonderful drug, but it can be made even better with manual therapy, with osteopathic, through the osteopathic lens. So very important. Okay, so GLP-1 supports the rate and quality of the replacement of the intestinal epithelium. It works through the gut-brain axis, modulates appetite, gastric emptying, and the vagal signaling that connects gut function to central autonomic regulation. In the OsteoSignal framework, there's a direct link between the gut peptide system and the autonomic layer that governs fascial tone, HRV, and treatment carryover. Now, it's been a while since we've done heart rate variability classes and discussed that a lot, but that is the change in the beat-to-beat variance in your heart rate. So people might think like, hey, if you have 60 heartbeats per minute, that would be 1 every second. Well, the more regular those are, the less healthy you are. We actually want your heart to be like a tennis player, nimble and on its toes and changing direction and moving, so that it's 700 milliseconds, 900 milliseconds, 1200 milliseconds, 1000 milliseconds a second, and keeps jumping around. Because as long as it's jittering around, it can handle changes and challenges and keep functioning just fine. If it's too regular, that's what helps break it down and then cause you cardiovascular disease. So it's an indication of cardiovascular disease when you don't have a high heart rate variability. GLP-1 helps that. So here's another way that we could go and watch our patients and see what they're, and I don't know if you still use some of those. I still have some patients that are using their heart rate variability to monitor effectiveness of treatment, right? Yeah, exactly. It's certainly one of the things that we look at and treat, because it's an indicator of disease process, and that's something we try to change.
Yep. And it's quick and it's not expensive to do. So it's nice. Not
Yeah.
invasive.
I mean, a lot
It's
of
great.
people have it on their phone. Yeah, exactly. You don't have to go through the whole. You can do the heart rate monitor, the chest strap and all that. A lot of phones have it, but yeah, it's a very useful tool, much more easily gotten to these days. Okay, so let's talk about GLP-1 and the chronic pain patient. Patients with metabolic syndrome, insulin resistance, or type 2 diabetes have chronically impaired GLP-1 secretion and reduced GLP-1 receptor sensitivity. Now, as you alluded to earlier, we go and treat the pancreas directly to get the inflammation out of there to improve that secretion and that receptor sensitivity. But this problem creates a triple deficit: impaired glucose regulation, elevated systemic inflammation from loss of GLP-1's anti-inflammatory action, and compromised gut barrier function. Okay. Clinically, these patients present with chronic musculoskeletal pain that doesn't respond to standard structural treatment. They have elevated C-reactive protein, poor treatment carryover, and often concurrent GI symptoms. Right? And this is a common pain patient coming into our offices. The GLP-1 deficit is not the whole story, but it is part of the biochemical environment that makes structural healing fail. So GLP-1 agonist medications, semaglutide, tirzepatide, are reducing inflammation in these patients independently of weight loss, and some clinicians are reporting improved musculoskeletal outcomes as a secondary benefit. And what would even improve that more is even more finely applied osteopathic manual therapy, right? I mean, if you know more about what you're doing, and as you said, do you treat the mid-back? Do you treat that portion of the intestinal tract? Do you treat the diaphragm? Do you treat the hindgut? Do you treat the thoracic inlet? What other things should be being treated with that? It does. I think what I'm always surprised with when I've gone to the clinics and I see how clinicians treat, and they're so focused on that 6-inch box that information like this is just beyond them, that they don't see that, well, but the patient came in with neck pain or they came in with chronic low back pain. Yeah, I don't, you find the source, find the why. Don't go with the where. The where is like, okay, great. That's great. You found where everything's breaking down, but why? Did you ask yourself
Yeah.
why?
Yeah. It didn't
Okay,
just wake up one morning and
GLP-2.
say, let's do it wrong.
I don't know. Yeah, exactly. Okay, GLP-2, the wall builder. GLP-2 is the gut peptide that almost nobody talks about, and it may be the most important one for understanding chronic inflammatory disease, right? So while GLP-1 handles the metabolic and immune signaling side, GLP-2's primary job is structural. It builds and maintains the intestinal wall. Specifically, GLP-2 receptor activation promotes crypt cell proliferation, intestinal stem cell expansion, and intestinal growth. It increases villus height, right? So we're back to those little villi. So if you got chubby ones, and the importance of that is if your villi are only this tall versus this tall, think of the absorptive surface area of a taller villus. So, for example, one of the descriptions I've seen is that the intestinal tract has the absorptive surface of a football field. That's pretty amazing. However, if somebody has shortened villi, then they don't have a football field to absorb. They have a much smaller field. They might be down to pickleball, not giving the pickleballers a hard time. Maybe they only have a pickleballer. No wonder they're having problems.
Yes.
But seriously, that is a problem. That if your absorptive surface area is decreased, how do you absorb nutrients appropriately? How do you take care of some of these things? So that's obviously a huge problem. Okay, specifically
I always think
GLP-2.
in my own head, I always think of our Lake Powell down here in southern Utah. They always say it's got more coastline than the Western United States because it's got so many little narrow fingers that go in there. But think of all the beach you have, right? Like all the access you have for that waterway. So that's how I always think of those villi, like that big lake.
Yeah, exactly.
Man, you got lots of
Exactly.
options then. Yep.
Exactly. So GLP-2 increases villus height, mucosal thickness, right, and absorptive surface area. And it enhances the tight junction proteins that seal the spaces between epithelial cells, the barrier that prevents luminal contents from leaking into the bloodstream. So again, between the cells, that tight junction that will stop leaky gut from occurring. Another big cause of gastrointestinal inflammation. Okay, so this is the leaky gut connection. When GLP-2 signaling is adequate, the intestinal barrier is maintained, tight junctions are intact, and luminal antigens, right, proteins, things that cause an immune response, bacterial endotoxins, and undigested food particles stay where they belong, in the gut lumen, not in the blood, where they can also be disposed of easily and left in the bathroom, not in the blood. And we've talked about heterochronic parabiosis, where we do neutral plasma exchange and take out all those nasty things that have gotten into your bloodstream, because those are causing inflammation throughout your brain and this and that, and they actually age your organs and age your brain. Again, here's another way that we would actually keep those things from occurring in the first place. If we keep them from getting into the bloodstream, that's even better. Okay. When GLP-2 signaling is impaired through gut dysbiosis, chronic stress, poor diet, or antibiotic damage, right, the barrier breaks down. Lipopolysaccharide, right, LPS, from gram-negative bacteria translocates into the bloodstream, and it causes massive inflammation. The immune system detects this as an infection signal and mounts a systemic inflammatory response. This is called metabolic endotoxemia, chronic low-grade inflammation driven by a leaky gut wall. And guess what? Hepcidin's, the liver starts producing hepcidin, all your iron's locked up, and you get more tired. Get more brain fog, you have upper motor neurons, can't tell you to fire your lower motor neurons effectively, et cetera, et cetera. As we've talked about in previous podcasts. So now here's why this matters for every patient you treat. Metabolic endotoxemia elevates the same inflammatory cytokines, tumor necrosing factor alpha, interleukin-6, interleukin-1 beta, that drive the chronic inflammatory loops we've discussed throughout this series. These cytokines elevate ferritin through nutritional immunity, impair T4 to T3 conversion, right? So you can't get your thyroid hormone for your cells, stalls the M1 to M2 macrophage transition, and maintains the tissue environment that prevents structural healing, right? You can't heal. Big problem. Now, we help cause a lot of these changes with our hands, right? By doing visceral mobilization, but GLP-2 can do it on a much broader basis. So it will be a huge boon when it starts being used. Okay, the gut barrier isn't just a digestive structure. It's the upstream gatekeeper for the entire systemic inflammatory environment, and GLP-2 is the peptide that maintains that gatekeeper, right? Got to keep the gatekeeper happy, otherwise. So teduglutide, a GLP-2 receptor agonist, right, is already approved for short bowel syndrome. So there it is. It's available. Research in animal models of colitis show it reduces pro-inflammatory cytokine expression and accelerates mucosal healing. This is not speculative. This is an approved pharmaceutical mechanism with direct evidence of gut barrier repair. Now, you're not hearing this on the evening news. I don't know why. Maybe because they don't want to talk about leaky gut or something. I don't know. Okay. Anyway, so let's talk about that a little bit more. Let's give an overview of that. GLP-2 in the leaky gut leads to systemic inflammation cascade. The healthy state, GLP-2 maintains tight junctions, crypt cell proliferation, and mucosal thickness. Barriers intact. Lipopolysaccharide stays in the lumen, not in the, and if you want to know what causes cardiovascular disease, say ALPS. And this is why when people eat poor nutritional food, fast food, ultra processed food, LPS, that food has tons of LPS in it. So it'll just be an aspect of the food itself. And of course, you're going to absorb that into your bloodstream. So the food itself is causing this exact chemical cascade of inflammation, right? That's why eating whole foods, not eating ultra processed foods, is so important, because your body thinks that bacteria are getting into your bloodstream and is reacting appropriately. It's going into full, but then you're doing this on a daily basis when you continue to eat food like that. So that's why that's such a negative consequence way to eat.
Well, and
now,
with the youth eating the way they do now, it's got to be starting earlier and earlier, and it'll be worse and worse for them as adults, because a lot of us ate healthier when we were kids, maybe because we didn't have all the ultra processed stuff. And now it's going to start,
we just didn't get exposed
sooner and get worse.
Yep, exactly. We didn't get exposed, so, and had a chance to get a normal gut health, even though it can be destroyed, obviously. But yes, good point. Okay. So, and we said in the impaired state, low GLP-2 signaling, dysbiosis, stress, antibiotics leads to tight junction degradation. Lipopolysaccharide translocates into the blood, metabolic endotoxemia. And then metabolic endotoxemia leads to a chronic elevation of tumor necrosing factor alpha, interleukin-6, interleukin-1 beta, ferritin elevation, nutritional immunity, impaired and ferritin elevation, meaning the ferritin levels might go up, but we don't have access to them. Impaired T4, T3 conversion, M1 macrophage stalling. This is the mechanism by which gut dysfunction produces systemic inflammatory disease that presents as musculoskeletal pain, fatigue, poor treatment response, brain fog. I just had a patient, and she was a classic she had 15, her ferritin was 15, and which is right on the line. And everyone was saying, oh, no, you're fine, you're fine. And of course, the physicians were so concerned about iron toxicity that they would not have her go get an infusion. So she got some Mega Foods blood builder, which actually worked amazingly well. Of course, she had had excuse me, she had had 2 GI bleeds at the same time.
Oh my goodness.
And yeah, they'd gotten that healed by put her on a proton pump inhibitor, got it healed. I took her off the proton pump inhibitor, but they weren't helping her with that. Her ferritin was right on the line of really terrible, chronically fatigued, is not responding. Now, this is a patient I've had for years. She comes, she goes, she comes, she goes. I've been seeing her lately, and she's just not getting better. And so, of course, let's get your labs. And of course, okay, you got your labs, but you didn't get the right labs because, ferritin and transferrin saturation rate are not a normal part of that. So we had to send her back. There had been, the physician is intended to do that, but it didn't get done. There was actually a lab screw up, but so she got that taken. It's like, oh, 15, this is terrible. They wouldn't give her the infusion. But she did start taking the blood builder, and she got up to let's say it's been 3 months. She's gotten herself up to 45 on her ferritin. And of course, everyone was like, okay, you can stop the blood builder. No more. You're doing great. Don't do any more than that. And I was like, and then she tells me and I had said, well, I disagree with that because, Harvard Medical says no, and Johns Hopkins says no, and Cleveland Clinic and Mayo Clinic all say no, 50 to 100. And with your advanced age, et cetera, and your history. And then also she says, oh, by the way, I had a guaiac stool test, and the physician said there were little spots of blood in that as well. So she's still continuing to lose blood, but and it was like her naturopath or somebody had said, oh, stop doing the Mega Foods. You don't need any more. You don't go overboard. And I was like, you have a constant loss of somewhere, lady. You are always losing blood. So stay on that for now until we see a 75. I don't want to see it change. But also, I treated her, and for the first time in months, she said, wow, am I supposed to be this fatigued from you treating me? She goes, that was the day you treated me and the next day. And I said, yes, because you actually have the ferritin, you actually have the iron to actually respond to the treatment. That means that your body was taking the energy from the other things and saying, let's put it towards healing. So we're round to the corner here. But, that's just it. Is she has exactly what we're talking about here, this chronic inflammatory state where she has a poor treatment response. And so let's see what
fantastic.
Yeah. And so that worked out well. The problem is that she's also somebody she had one of the reasons she had the GI bleeds is that she had a gastrointestinal infection. She went down to Guatemala. She ate street food. It took her a while to find an infectious disease physician who knew tropical diseases, who actually he spent time down in Guatemala, so he knew all about it. And he immediately was like, oh, you've got this. And she goes, what? Never heard of it. He goes, oh, yeah, if you've been to Guatemala and you got sick, this is what you have. And so he treated her for that, and that was great. But then the low iron didn't get treated. But this is when you might have wished that they had also done a GLP-2, said, why don't you take this GLP-2 to help your intestinal tract heal to overcome this? So I think that's coming.
Yeah. It would make sense.
We want to know about it out in front because you're going to start seeing it. More and more physicians will start prescribing for that. So we want to know what that is. So the clinical implication is any intervention that restores GLP-2 signaling, whether that's our hands. Now, some of those are dietary fiber, prebiotic supplementation, gut microbiome restoration, GLP-2, visceral manipulation. Anything that addresses systemic inflammation at its source helps with this GLP-2 signaling. So that's the end point of the point I'm trying to make. Okay, let's move on to GIP, the multi-named GIP, gut insulinotropic, or what is the gut dependent insulinotropic polypeptide. Okay, The gut-bone axis mediator. So this is a really important one for us because we just did one of the podcasts on bone marrow inflammation and how that creates an environment where cancer is more likely to grow. So this is one of the things that we want. If that inflammation is also being driven by the gut, we want to know that. And we want to, A, as practitioners, we're going to treat that, but B, also knowing that this patient might be, maybe it's time to send them back to the doc and say, hey, have you looked at this? Anyway, glucose dependent. So GIP, glucose dependent insulinotropic polypeptide, is a third member of the endogenous triad, and it has a role that directly connects to our earlier episodes on bone metabolism and pre-exercise calcium. GIP was the first incretin hormone identified, so before GLP-1, GLP-2, originally recognized for its role in potentiating glucose-stimulated insulin secretion for pancreatic beta cells. But emerging research has expanded its physiological relevance far beyond glucose metabolism, particularly into bone biology and gut immunity. In bone, GIP has a dual action that is almost unique among gut hormones. It both inhibits osteoclast differentiation and activity and promotes osteoblast-mediated bone formation. In human studies, exogenous GIP administration suppresses the CPX1, the bone resorption marker, and increases P1NP, the bone formation marker. This is not just reduced breakdown, it's reduced breakdown and increased building simultaneously. So you get and obviously that's one of the biggest problems. Like normally we do want to see some level of bone breakdown so that we can put new bone in there. The problem is that we're getting way more bone breakdown than we are bone building. The bone building falls behind, and that becomes osteopenia, and that becomes osteoporosis. In this case, what we're doing with the GIP is that we're actually reversing that. So you're going to see this in patients. If the patient is on Mounjaro, that's a great time to look and focus on treating the bones. Now, one of the important parts of this is as the patient gets older, particularly over the age of 25, their hematopoietic centers where they make bone is not. It's supposed to be long bones, but it's always some rim of the bone. Obviously, when they go to test for like something like Waldenstrom's macroglobulinemia, which is a bone marrow cancer, they actually take a sample of the bone marrow from through the iliac crest, right near the PSIS.
Mhm.
So it does tell you that there is hematopoietic centers in the ileum, in almost all of your bones. Most of that is occurring in the ribs, which is why we often work on the ribs. Even though somebody says, I have low back pain, I have knee pain, I have this, I have that, we have to make the rib cage. The sternomanubrium has a lot of hematopoiesis. You have to make sure all those structures are working correctly, which not many people know how to do. Okay. So that's why that's such an important thing, that we decrease the amount of bone resorption and increase the amount of bone production. And this is what's known as the gut-bone axis. Every time you eat a meal, the K cells in your upper small intestine release GIP, which signals to your skeleton to shift from a resorptive state to a formation state. This is why bone resorption follows a circadian pattern. During the day, when you're eating and GIP is elevated, bone resorption is suppressed. At night, when fasting, that reduces GIP levels and bone resorption increases. The skeleton literally rebuilds itself according to your feeding cycle. And in the gut itself, recent research from 2025 published in the Journal of Clinical Investigation demonstrates that GIP receptor signaling directly alleviates gut inflammation. Using gain of function and loss of function studies, the researchers showed that GIP attenuates 5-fluorouracil-induced gut inflammation, while genetic deletion of the GIP receptor exacerbates the inflammatory response. So they were able to prove specifically that GIP is in charge, really can inhibit gut inflammation. The anti-inflammatory action was localized to bone marrow-derived cells and stromal CD146 positive cells in the gut wall. So this information flows straight from our last podcast on bone marrow. When people have bone marrow that's dysfunctioning, that means they have gut dysfunction. So if you're going to treat a joint, you have to treat the gut. Otherwise, the joint can't properly remodel, can't heal. If you continue to have gut inflammation, your joint treatment, your bony treatment, your musculoskeletal treatment will fail. There you go. And that's why in our osteopathic manual therapy, we focus so much on visceral manipulation, And a lot of people go, oh, that's hogwash. That's not this. That's not that. I don't know. Seems like the newly published research is showing more and more how important that is. Okay. Not to beat a dead horse here. Okay. This finding is particularly relevant because it means that the new generation of GIP-containing dual agonist medications like tirzepatide, which combine GIP and GLP-1 receptor activation, may provide gut anti-inflammatory benefits beyond what GLP-1 agonists alone deliver. So again, why we're going to start seeing these medications, and we might advise patients go speak to their physicians about these medications and not stay on Ozempic, but move on to Mounjaro, right, the tirzepatide, so that they receive the benefit of the GIP with it, especially when you see bone problems. And then that way, when they're on the tirzepatide, you can treat them, and you have to educate your patient about, yes, it's important to move from one to the other, and it's important to do this one because it will help. And then this knee problem, this chronic knee problem that you have that won't heal, is more likely to heal, and I can help direct that healing, right? So that's important for us to understand and to know. So the clinical implications for patients with both metabolic disease and inflammatory gut conditions are substantial. Okay, let's go over a patient case. Denise, name's changed to protect the not so innocent, 58-year-old with metabolic syndrome and chronic low back pain, right? Presentation, 6-year history of chronic low back pain, rated about 5 to 7 out of 10, refractory to multiple treatment approaches, right? Just not responding. She, of course, has type 2 diabetes, hemoglobin A1C of 7.8%, BMI of 34, chronic bloating, irregular bowel habits, and fatigue, rated at 7 out of 10. She's always fatigued. She's always tired. She would love to work out, but she's just too tired. Now, labs, ferritin, 142 nanograms per milliliter, elevated, likely due to inflammatory causes. CRP, C-reactive protein, 8.4. Ooh, that's high. That's elevated. Transferrin saturation, 14%. So our body has iron, but low. So our transferrin saturation, low. Functional iron deficiency masked by inflammation. Free T3 is 2.4, which is low. Fasting insulin, 22. That's not normally how we measure that, but that's what the lab said, so it's elevated. Okay, so interpretation. Classic metabolic endotoxemia pattern. Insulin resistance impairing GLP-1 and GIP signaling, likely gut barrier compromise, driving systemic inflammation, elevated ferritin masking functional iron deficiency, metabolic triad failure across all 3 nodes. Okay, so the low back pain was real and structural. Lumbar segmental restrictions were present, but every structural treatment provided only 2 to 3 days of relief because the systemic inflammation environment regenerated the tissue tension and nociceptive input. Never mind the gut inflammation that is also causing her to torque her back.
Mm-hmm.
The treatment approach, endocrinology referral. She, sent her back to her doctor and said, hey, kind of talked to her about, has she considered these things? Has she talked to her doctor about those? She had been a little reluctant, and her physician had actually suggested it to her, and she'd been a little reluctant. We talked about why that would be beneficial to her with the gut inflammation and this, that, the other. And so once she understood that, so she went back to the physician. She started on tirzepatide, which is the Mounjaro version, or the GIP GLP-1 dual agonist, anti-inflammatory dietary protocol, right? She's got rid of a lot of this ultra processed food as best she could.
Mm-hmm.
She also kind of said, hey, yeah, I always flare up when I'm having dairy. So she knocked off most of her dairy and stuff, et cetera, et cetera. She decreased her gluten, but I don't know that she's fully gluten intolerant. But so that targeted gut barrier restoration, right? Talked about fiber, prebiotic rich, elimination of processed food, iron repletion once CRP began declining. So once the tirzepatide, she was on the tirzepatide, we talked about, okay, now you have to make sure you're getting that iron. Blood builder, Mega Foods blood builder. They're gonna have to pay us for these ads, right? And then we continue the manuotherapy weekly, right? Kept working on her back, working on her musculoskeletal system, trying to get her back, helping with the inflammation, getting her body to process that inflammation, work on her liver, et cetera, et cetera. So after 12 weeks, hemoglobin A1C is 6.9, which is, hey, that's not down where we want to see it, but down from 7.8 in 12 weeks. That's pretty good. CRP 2.1. Yes. Ferritin was 88 nanograms, climbing towards genuine storage value, right? That's actually where it should be, more what a real number is. Transferrin saturation rate, 22%, normalizing, right? Yeah. So coming up, right? bloating was resolved. She says, that's one of the things. She didn't have that bloating. Now, her low back pain now is about 2 to 3 out of 10. So she has low back pain. It's more episodic at this point. The treatment carryover is extended from like the 2 to 3 days of feeling better to 10 to 14 days, almost 2 weeks, sometimes a little bit longer, sometimes a little bit less, depending on what she's been doing. Then at 24 weeks, right? So that was the 12-week mark. At 24 weeks, CRP was 0.8. Her free T3 was 3.4. Yeah, it was down. Low back pain, no real low back pain. I mean, again, episodic here and there, she'll do something and sets it off, but I'm down to seeing her once every 4 to 6 weeks. So the key learning here was the structural treatment was appropriate, but the biochemical environment driven by gut peptide dysfunction and metabolic endotoxemia made it impossible for the structural work to hold. Restoring gut peptide function through pharmacology and dietary intervention changed the biochemical environment, and the same manual therapy techniques that had failed for 6 years. I mean, I hadn't treated her for 6 years, but she's been seeing various people. Suddenly produced lasting results, and her food's better. She's actually able to exercise and do her exercises on a regular basis. She's pretty happy with that. So there you go. I mean, and that was just getting her on the tirzepatide and then providing her appropriate treatment. And again, like I said, there's a lot of little add-ins that we do, but you know how that goes.
But that's exactly what we're talking about, getting people to thrive,
Right. Doing all those things that help her. I mean, to get her CRP down that low, that relatively quickly, honestly, was that was a touchdown there. So, okay. BPC 157, the body protection compound. So now let's talk about BPC 157, body protection compound 157, because this peptide sits in a unique position in the gut repair landscape, and its mechanisms directly complement the endogenous trio we've just covered. Now, those ones are all already approved. They're already on the schedule for physicians to be able to prescribe. I think that the GLP-2 is not really being known. It's not getting the name out just yet. I'm expecting that they will very shortly have a GLP-1, GLP-2, GIP compound. I can almost guarantee you that's the next one to come out. But BPC 157 has not been placed on that schedule. It's not available. Doctors cannot prescribe for it just yet. But let's talk about it a little bit more. BPC 157 is a synthetic pentadecapeptide, 15 amino acids, derived from a naturally occurring protective protein found in human gastric juice. It was first described in the 1990s by Predrag Sikiric and colleagues in Zagreb, Croatia, and has been subject of over 30 years of preclinical research with a remarkably consistent profile of tissue protective and regenerative effects. Now, I myself take this. I do get a gray market, so there you go. And we talked about Pavlov and how Pavlov was using this. He hadn't discovered the exact pentadecapeptide. That was by Predrag Sikiric, but he knew of its healing powers. Now, here's an aside. There is a fairly famous weightlifter. He does all sorts of podcasts and this, that, the other. And our friend Josh, he put us onto this guy, but the guy tore his biceps. And I think in one of our early podcasts, we were sitting around talking to Josh about peptides. And I believe Josh talked about this, where the guy had torn his biceps. I don't think it was a complete tear, but it was a pretty significant portion of his biceps he had torn. And he started injecting BPC 157 into the area that it was torn. And in a very short period of time, he was back to lifting weights, which it was way faster than what you would expect normally. So there are some really, a lot of anecdotal evidence on BPC 157. It can be very useful. And the thing is that what I have read is that if you take it in lower amounts, then and it comes in pill form. If you take it in lower amounts, it is good for the gastrointestinal tract. But that if you take it in higher amounts, more on the order of a gram, is what I read somewhere. They were discussing that was actually when you start seeing tendon, muscle, ligament repair improve. And obviously, if you improve the gastrointestinal tract, if you decrease inflammation, if you do all these things, that's going to occur also naturally as a side effect of that. But BPC 157 has been either orally or injected, has been anecdotally seen to have a lot of positive attributes.
So are you injecting it or are you using the oral?
No, I'm just using the oral.
Okay.
I don't have any injury right now that I would inject that to. But like I said, there are plenty of people online
I don't
that
know. I've
show
seen your
like this
knee.
guy. Right. Well, yeah, my knee is actually doing great. So thank you. Yeah.
Oh, good. I'm glad.
That healed right up. So yeah. So no, there's a lot of people who actually will show, they go, okay, I'm going to show you what we're going to do. And they keep injecting it. And then they do time-lapse video and show how it comes back. So interesting. It would be interesting to have the studies on this so they can be placed into we'll see what's going to come up, because in this fall, the FDA said that they were going to come up with some conclusions on some of this stuff. So we'll see what happens. Now, what makes BPC 157 unique among peptides is its ability or its stability in gastric acid, which is why you can take it in pill form. Most peptides are destroyed by the acidic environment of the stomach. BPC 157 is not. It retains biological activity when taken orally, which means it can act directly on the gastrointestinal mucosa from the luminal side. This is it comes from in the lumen and in the gut space and it can go through, because it doesn't get destroyed. So the mechanisms of action are multiple and converging. First, BPC 157 upregulates vascular endothelial growth factor, VEGF, right? Vascular endothelial growth factor. The endothelia are the cells that come together to make the tube. And then the receptor for that, VEGFR2. This drives angiogenesis, right? The angiogenesis means the production of blood vessels. The formation of new blood vessels at sites of tissue damage. Increased vascular supply delivers more oxygen, more immune cells, and more nutrients to the repair site. In the gut, this translates to accelerated mucosal healing, right? So along with the GIP and the GLP-2, this would be a very good thing to put together with that, right? And so again, I'm waiting for the physicians to come forward with some of this stuff, but it's something for people to consider or to talk to their doctor about. And again, like I said, this fall. So second, BPC 157 upregulates epidermal growth factor and fibroblast growth factor, FGF. EGF directly supports epithelial and mucosal healing. FGF drives fibroblast proliferation and connective tissue regeneration. Together with VEGF, these growth factors create a coordinated pro-regenerative signaling environment. So epidermal growth factor, that might be helpful for people's skin. Okay, third, BPC 157 modulates the nitric oxide system in a unique way. Rather than simply increasing or decreasing nitric oxide production, BPC 157 acts as a bidirectional modulator. It counteracts both nitric oxide excess states and nitric oxide deficiency states, depending on the physiological context. So in other words, it's a gatekeeper. It keeps, or it's bumpers at the bowling alley. It keeps you from going off either side, right? So it's very useful that way. But it's often one of the problems with some compounds is that, yeah, a small amount is good, but a lot is really terrible. And so, and most of us think, well, if a little bit's good, a lot's going to be even better. And sometimes that's definitely not true, right? That's a common problem. Fourth, and most directly relevant to our conversation, BPC 157 enhances the integrity of tight junction proteins, right? The same proteins that GLP-2 supports through a different mechanism. So BPC 157 reinforces the barrier between epithelial cells, preventing the translocation of luminal antigens and endotoxins into the bloodstream. So your lumen is your gut space, right? Your food is in here and it's being digested. And those tight junctions keep it there. And only certain things go through these cells and come out to the other side on the blood, into the bloodstream. And those tight junctions keep things from being able to just go straight in. But if those tight junctions break down, now the food or other things that are in your gastrointestinal tract go from here, they're able to go straight and bypass the cell and get in there where the cell would normally say, nope, sorry, you can't come in here. They're able to get directly into the bloodstream, like we talked about, like lipopolysaccharide, cause inflammation, cause irritation, cause infection, et cetera, et cetera. Well, that's what BPC 157, helps prevent that by preventing the translocation or the separation of luminal antigens or the translocation from one space to another of antigens and endotoxins into the bloodstream. It does this through promotion of tissue granulation and organized epithelial cell proliferation, effectively rebuilding the compromised gut wall from the luminal side. Now, fifth, BPC 157 reduces pro-inflammatory cytokines, tumor necrosing factor alpha, interleukin 6, at injury sites without the systemic immunosuppression that characterizes NSAIDs and corticosteroids. So, in a lot of ways, it is going to help decrease pain at injury sites. Not immediately, but in general on the overall. The inflammation goes down, but the immune system stays functional. It's like, well, that's optimal because a lot of, if you use too much NSAID, it'll actually inhibit the immune system from rebuilding the tissue, right? So that's a particular problem. Okay, right, and obviously corticosteroids really highly inhibit your immune system and your healing system. So you really don't want that immunosuppression. You want appropriate immunology, but not all the extra inflammatory products that cause problems. Now, sixth, the list goes on. And this is what connects BP7 to the broader OsteoSignal framework. BPC 157 protects against NSAID-induced gastrointestinal damage. NSAIDs are among the most commonly used medications in musculoskeletal practice. They work by inhibiting cyclooxygenase enzymes, which reduces pain and inflammation, but also strips the protective prostaglandin layer from the gastric and intestinal mucosa. Right, like we talked about earlier, you've got those villi, but you should have mucus here. But NSAIDs strip that away and then lay these cells bare to direct contact with bacteria, et cetera, endotoxins, chemicals. So, and then that wears them away sooner, more easily, et cetera. And so you can just see how this builds as a bigger and bigger problem. BPC 157 helps overcome that. So BPC 157 has been shown in multiple animal models to protect against and reverse this damage, maintaining gut barrier integrity even in the presence of NSAID use. So,
wow.
And again, yeah. So when this is coming out, and these people who they're saying, yeah, but I need the NSAIDs, I can't sleep, or this, that, the other. I think a lot of us will be sending our patients back to the doc saying, hey, can this patient get a prescription for BPC 157 because of the chronic NSAID use that they've been doing? Which would be awesome, right? Okay, now I'm going to include the mechanisms of actions of BPC 157. I've got some charts of stuff. Brent's going to put that in there. I hear him already. Okay, now, so let's bring this all together. Let's put this together and say, well, Neal, why are you talking about all this? I mean, obviously, this is going to magnify what it is we do as osteopathic manual therapists, and we're going to magnify what they do. So that's certainly a good direction to go with things. But a lot of these medications are going to be very useful. So now let me show you how these 4 peptides form an integrated system, because the interactions between them are what make this clinically powerful. When a healthy person eats a meal, the following happens simultaneously. K cells in the upper small intestine detect nutrients and release GIP. L cells in the distal small intestine detect nutrients and release GLP-1 and GLP-2 in a 1-to-1 ratio. And BPC 157, constitutively present in gastric juice, continues its baseline protective and reparative activity across the gastric and intestinal mucosa. That's normal, when we were back when we were 20. GIP signals the skeleton to suppress bone resorption and promote bone formation. This is the gut-bone axis at work. Every meal protects bone. GLP-1 signals the pancreas to release insulin, signals the brain to reduce appetite, and, critically, signals immune cells in the gut wall to downregulate pro-inflammatory cytokine production. GLP-2 signals the intestinal epithelium to proliferate, to expand stem cell populations, and to strengthen tight junctions. And BPC 157 supports all of this by maintaining the vascular supply to the mucosa, upregulating the growth factors that drive epithelial renewal, and modulating nitric oxide to prevent ischemic or oxidative damage. Right, there we go, ideal system. The system is elegant in its redundancy. GLP-2 and BPC 157 both support tight junction integrity, but through different mechanisms. GLP-2 through receptor-mediated crypt cell expansion, and BPC 157 through growth factor upregulation and direct epithelial proliferation. GLP-1 and GIP both modulate inflammation, but through different immune cell populations. GLP-1 through intraepithelial lymphocytes, GIP through stromal CD146 positive cells, and bone marrow-derived cells. The quartet covers the same functional territory through complementary and partially overlapping pathways, right? This redundancy means that the system is resilient. Losing one pathway doesn't collapse the whole system, but it also means that when multiple pathways are impaired simultaneously, as happens in metabolic syndrome, chronic stress, gut dysbiosis, or prolonged NSAID use, the failure is cascading and multisystemic. The barrier breaks down, the inflammation rises, bone protection is lost, and the tissue repair environment degrades, and the patient presents to you with chronic pain, fatigue, poor treatment response, and a constellation of gut symptoms that seem unrelated to their musculoskeletal complaints, but are, in fact, the upstream driver of everything. You have to work on the gut. Okay? So again, kind of beating a dead horse there. With that definitely, not only as an osteopathic manual therapist, you have to work on the gut, but also recognize when you need help, right? That we need to help restore this patient, and we need the physicians. Okay. So now let me connect all this to the OsteoSignal framework and give you the clinical action steps. The gut peptide quartet governs the biochemical foundation on which the entire OsteoSignal healing loop operates. GLP-2 and BPC-157 maintain the intestinal barrier that prevents the metabolic endotoxemia, which drives systemic inflammation. GLP-1 provides the immune modulation that supports the M1 to M2 macrophage transition we've described as essential for tissue healing. GIP provides the postprandial bone protection that prevents the skeletal resorption we recovered in our pre-exercise calcium episode, And PPC-157 provides the tissue repair infrastructure, angiogenesis, growth factor signaling, and nitric oxide regulation that supports healing at every anatomical level from gut mucosa to tendon to fascia. When the quartet is functioning, the body has the biochemical environment it needs to convert the mechanical signals we deliver through manual therapy into lasting structural change. When the quartet is disrupted, the body cannot sustain the adaptation, and our treatments don't hold. So the first thing I want everyone to take from this is, if you're not treating stomach, if you're not treating small intestine, if you're not treating the liver, if you're not treating the pancreas, if you're not treating the small intestine and the large intestine, if you're not treating that entire system, every time you have a musculoskeletal problem, you're not getting back to the reason that this patient is seeing you, right? People often have injuries, and they often heal from those injuries all on their own. Why is this patient different? Why are they not getting better? That's because these other factors have come into the picture and need to be taken care of. So even if the patient's not going to go on these other medications, right? Not every patient's going to go through that. Maybe you have them and they don't have these problems to that level yet, right? You as a manual practitioner, or you as a patient, needs to recognize that and demand, hey, I want somebody who's going to help me take care of these issues now. I do need my gut worked on. And you need somebody who knows how to work on the gut, not just that they poke, and I manipulated it, poke. Understanding how to get around to the sides, how to get around to the back, understanding that the front to back of the organ are different, and understanding how that organ drains inflammation.
Yep. And how they tie in with different systems and things like that too. So you got to treat all those different handles.
Exactly.
And so any practitioners listening, come to class, because Neal teaches us how to do this all the time, and it works fast. So.
Well, and we've learned this from some very, very intelligent physicians, osteopathic physicians, MDs. Bennett was a chiropractor. I mean, these people did amazing amounts of research, learned amazing amounts of things, and what we do is just bring all that information to bear and integrate that information and say, let's present this as a united whole. Like, how do you treat a patient? How do you do all of this stuff? Because you can't take one view, and just say, oh, I have this one tool. I'm just going to poke I'm going to hit everybody with my hammer. Okay, now I'm going to poke everybody with my screwdriver. Okay, now I'm just going to use my battery on everybody. It's not how it works. You have to know when and how to use those tools all together as one.
Yeah.
And that's
well,
really
just like
what
we were talking about
provide.
Using these as in stages, like maybe you start with GLP-1 and then you go, move to the Manjaro, and then and we have to do that with treatment too. You can't just give the same recipe all the time and give everybody the same treatment and give the person that you're on your table now the same one you gave 2 hours ago. They're not the same. So, and there are different stages and stuff. You have to be able to adapt.
Exactly. So in the end, every patient coming through the door, you should screen for gut symptoms in every chronic pain patient: bloating, reflux, irregular bowel habits, food sensitivities, post-meal fatigue. Those are huge markers for gut peptide dysfunction that may be driving the systemic inflammatory environment, preventing structural healing. Consider the antibiotic history. A patient whose chronic pain began within months of a significant antibiotic course may have gut barrier compromise as the upstream driver. Microbiome restoration is the treatment, not necessarily more manual therapy. So, and that's the whole problem, is understanding history, the history of the patient. Where should you, what are the things that need to be addressed first? Support endogenous GLP-1 and GLP-2 through diet, dietary fiber, particularly prebiotic fiber from sources like chicory root, garlic, onions, leeks, asparagus, Jerusalem artichokes. I guess they have more fiber in them. Those all stimulate L-cell GLP-1 and GLP-2 secretion. So that might be the other thing, is that you suggest to your patient, hey, look, before you come in, why don't you eat something that has fiber in it? Short-chain fatty acids produced by microbial fermentation of fiber, particularly butyrate, are among the strongest stimuli for L-cell peptide release, right? So having your patient say, hey, why don't you eat just a couple hours before you come in and make sure that you get a huge load of dietary fiber. That way, when I go and work on your gut and the rest of your musculoskeletal system, it will be responsive to that treatment. Protect the gut barrier in NSAID users. If your patients are on chronic NSAID user, or they're a chronic NSAID user, you have to get them off the NSAIDs if you can, or at least decrease that, because that's actually leading directly to the inflammation, the chronic gut inflammation, that's making your treatment not stick. Okay, so if your patients are taking NSAIDs regularly, they are stripping the protective mucosal layer of the GI tract. Discuss it with them. L-glutamine provides direct enterocyte fuel, BPC 157, where available, through appropriate clinical channels, addresses mucosal repair directly. So something else to discuss with him. Connect meal timing to bone protection. Every meal triggers GIP release, which suppresses bone resorption. Patients who skip meals or fast excessively are losing this GIP-mediated bone protection. This connects directly to our pre-exercise calcium episode. Eating before training is not just about calcium supply, it's about triggering the GIP-mediated shift from bone resorption to bone formation. If your patient is osteopenic or osteoporotic, and they go and they work out for more than that 45 to 60 minutes, it's very important for them to eat a meal before they work out. And that it's a big thing right now for a lot of people to say, yeah, I'm doing intermittent fasting, and I do my intermittent fasting, and then I'll go do my workout. But I'm going to go do my big workout because I really get that burn out these cells, and et cetera, et cetera. Look, if you eat a really healthy meal that is really focused on dietary fiber, that has a bunch of calcium in it as well, then you if you use that, then you'll actually protect your body from what's going to happen to it when it goes through the exercise. So yes, you can do fasting. Intermittent fasting is great, but you also be very, very careful with how you use it. That is a medical prescription. It's not just something, oh yeah, just fasting. We'll just do fasting all the time. It's great. You have to be very careful with that, especially with people who have osteopenia, osteoporosis. Okay, recognizing that gut peptide dysfunction and the metabolic triad overlap. Impaired gut barrier, GLP-2 deficit, produces systemic inflammation that elevates ferritin, impairs T4 to T3. And it elevates ferritin because your body's not able to take the ferritin, so that your body's not using the ferritin, keeping the ferritin level at a lower rate. The ferritin gets really high because your body can't get to it and use it. So your transferrin's not moving it out of the ferritin because hepcidin has locked it up. Okay, so that's when we say that elevates ferritin. People are like, oh, don't you want high ferritin? You want your ferritin up, but you don't want it so elevated because that means your body's not able to use it, right? That's one of the reasons it's elevated. Okay, it also impairs T4 to T3 conversion, right? So you don't have thyroid hormone to use. So they're going to be fatigued. They're not going to respond to a workout. They're not going to respond to manual therapy. And because that reduces mitochondrial output. They just don't have the energy for it. The gut peptide quartet and the metabolic triad are not separate problems. They are different entry points into the same downstream failure. When GLP-1 agonist medications are in the picture, recognize the multi-system benefit. Patients on semaglutide or tirzepatide are receiving pharmacological GLP-1 and, in tirzepatide's case, GIP activation. Monitor for improvements in inflammatory markers, treatment carryover, and tissue quality. These may improve independently of weight change, and they affect your structural treatment outcomes. So use them as the tools that are there to magnify that. You might make sure that, for example, those are the patient takes a shot once a week. So what you would want to do is you wouldn't want to treat them on day 5, 6, or 7. You would want to treat them on days 1, 2, or 3. Right? So when they're gonna give themselves the shot, say, hey, can you make sure that you're scheduling your appointments within a day or two of taking that, and definitely not the day before you take it, right? Because because we might as well make use of having these available to us. And there's the information that the patient needs to know, and like your workouts. If you're gonna go work out, definitely get your workouts right after you've given yourself the shot, right? Don't wait until days 5, 6, and 7 and go, oh, I really got to get these workouts in. I'm really going to pound myself. And then on Sunday, I'll take this medication. Now, some of that is that the medications can cause nausea. And so people are like, oh, I don't feel like working out because I'm nauseous. So we have to figure out a way to balance all that out and find out, why is the patient not exercising in days 1, 2, and 3, and they're waiting till 5, 6, or 7 when it's actually more damaging to them than helpful to work out. Okay. Again, good information for everyone to understand. And to be able to use. I mean, this is the kind of things we need to be able to tell our patients. Okay. All right. That's the episode.
This is really helpful. Yeah.
Yeah, good. I think we'll go down this track for a while. We'll discuss more and more of this. There's some other peptides. I would at least like to discuss what they do and why people might benefit from them. And again, that's because the FDA will be coming out with these, and some people are getting a hold of them now on the gray market, and they're not necessarily sure how they should use them. So we want to talk about what does the medical community say? What is the information we have available to us, and how we will be using these in the future so that people can look forward to this.
Yeah, because it's going to come out at some point, and it won't be too long because there's too much to be made with it. So
there's a lot of money, but there's also a ton of health to be done. I mean, the thymosin, like making the thymus gland work better, like bringing it back. Involution is when the thymus gland kind of dies off and turns into fat. You can actually de-involute, right? Your thymus gland will come back. So there's supposed to be some maintained centers of cells still training T cells in the thymus gland. And they've actually shown that people who have that continue to have activity later in life in their thymus glands live longer, right? It is a measurement of, so in the longevity crowd, that's going to be a huge one. If you're now, what are we going to do about that? Considering that the thymus sits right underneath the manubrium, affected by the clavicles, C7, T1, T2, T3, ribs 1, 2, and 3, and the sternocleidomanubrial joint, the breathing mechanism. That's what we do, folks. We improve how people breathe, how their upper extremity integrates into their body. An upper extremity problem is going to stop rotation. Like I like to say in class, that upper extremity rotation drives thyroid and thymus function. If the upper extremity, cannot rotate appropriately, you're not driving fluid through these areas, and the thymus is going to involute, and the thyroid's is going to be inflamed, and you're more likely to get thyroiditis, and it won't function as well. We want to maximize that. That's what we do as osteopathic manual therapists is that we maximize how the body functions. And then if we can use some peptide that will magnify that effect, well, if we work together with the peptide, understanding it and making it work better on whichever target it's designed to work on, whether that's the brain, whether that's the base of the brain, the cerebral cortex, the thymus, the neurohormonal axis, the this, the that. As you can see, as we've gone through this, yes, that's exactly what we do. We take a lot of things and make them work better. So not everybody's going to have the same effect from these, and I can tell you why they're not going to have the same effect. People can take thymosin or some of the other ones, and they're not going to get the effect that they should have gotten because they're too stuck through here and it can't grow. Mm-hmm. What if their gastrointestinal tract is inflamed, or their stomach is they have gastritis? If they have gastritis, they're not producing BPC 157. Then using peptides to grow your thymus gland is not going to work. So you can see it's a very complex interaction, but you really need people who know what they're doing with the entire body. Now, the 4 peptides we talked about today, GLP-1, GLP-2, GIP, and BPC 157, they together govern gut barrier integrity, immune regulation, bone metabolism, and tissue repair. A signaling system that operates with every meal, that is disrupted by metabolic disease, antibiotic use, chronic stress, and poor diet, and that when it fails produces the systemic inflammatory environment that makes chronic musculoskeletal conditions treatment resistant. Right? So the big idea today is this: the gut is not separate from the musculoskeletal system. It is the upstream regulator of the biochemical environment in which the musculoskeletal system operates. GLP-2 and BPC 157 maintain the barrier that prevents endotoxin-driven inflammation. GLP-1 modulates the immune cells that drive tissue healing. GIP protects the skeleton that supports the entire structural framework. And when all four are functioning, the body has the conditions it needs to convert mechanical input into lasting structural adaptation. Not only our treatment, but exercise, activity that are supposed to keep us all healthy. And we have patients who are coming in chronic condition, chronic inflammatory states, that exercising actually deteriorates their condition. And that's how we turn this around. So for the clinician working with chronic pain patients or the chronic pain patients themselves, who don't respond to structural treatment, look at the gut, ask about the symptoms, ask about the history, support the peptide system through diet, microbiome restoration, appropriate clinical interventions. You got to come to the visceral manipulation classes. We definitely do some things. I mean, just on the cardiovascular tree itself, I don't know how many people are mobilizing the heart because they don't understand that the heart actually has a skeleton, a fibrocartilaginous skeleton, and that if that gets deformed by deformation of the chest, then the heart cannot beat freely and evenly. If it's constrained in a cage, then the cage is twisted, then the heart's not free to beat appropriately. That's going to break the heart down. You have to come to class, learn how to do this stuff. And that's how, and watch what happens to the patients who've been stuck for years when you finally address the upstream driver that nobody was looking at, whether that's the nutritional stuff that, like looking at their blood panels, understanding that aspect of it, looking at this aspect of it. How is their signaling system? And certainly this is a big part of the biochemical cascade. And that's what makes us different, that we treat biomechanically, bioelectrically, biochemically. So if you find this episode useful, share it with a colleague, leave us a review, and send your questions and case presentations through Neal at pursuitpt.com. I'm Neal O'Neill with Autumn Mayberry and Brent Mayberry. Thanks for being here, guys. So keep learning, keep looking deeper, and I'll see you in the next one.
Thanks for joining us for this episode of OsteoSignal. For more information, visit pursuitpt.com or pursuitperformancetraining.com. Want to show your support for the podcast? Like this episode, hit that follow or subscribe button, and leave us a comment or review. Remember, this podcast is for informational purposes only. Please consult your healthcare provider regarding any medical procedure. Copyright 2026, Neal O'Neill, PT.